Okay, team. Welcome to tonight's round session.
Started talking. That's why.
They working now?
Yeah.
You guys all right there? Yep. We're fortunate tonight. We're joined by Lalith, Gamage, who's a paediatrician here in Adelaide. He works at the Women's and Children's Hospital and also runs a private clinic called Priority Paediatrics, which is a really good service for the doctors here in South Australia. And he's going to talk to us tonight about abdominal pain in children, which is a topic that frequently comes up in our rooms all the time. If you have any questions, just put them in the chat. Our IT's had a slight issue today, so we will get to it as soon as we can, but just pop it into the chat, and that's probably the easiest option. So I'll pass us over to Lalith.
Thank you, Jared, and thank you very much for giving this opportunity. So I think it's a great topic, and I will try to justify the topic as much as possible. And apparently this is one of the common presentation to the emergency department. It's not only rooms, and it's a very challenging because quite abdominal pains are not straightforward and non-specific. So yeah, give me a second. Yeah. Okay. Yeah. Okay. Now, so the abdominal pain, I'm not reading the slides out, but main reason for abdominal pain, so objectives is abdominal pain is find out what sort of abdominal pain are presenting and what sort of investigation, examination, what are the differential diagnoses, when to send the referral to the gastro, or when do you going to send it to referral to emergency department, or how concerned you are. And what are the investigations available? What sort of things looking for line of thinking? Okay, this is abdominal pain, I'm concerning. And what are the tools available? How do we examine? All these things we are going to talk about in next half an hour, I believe, or 45 minutes, half an hour. And if you have any questions and things, and let me know. And first patient, I think I thought of is having a bit of case presentation just as a start or entry. So this is a common presentation again to we have seen in the emergency, so it's not uncommon, but this been disregarded many times by many physicians, including myself. So this is not a new thing. We might do the same mistakes again and again, but I thought of starting with this non-abdominal pain case, and we'll go from there. Now, just to make it cut short, so I will tell you the story. So we had about almost 2-year-old and having a fever, cough and cold, running nose for a couple of days. And he was arching back and coming with tummy pain. So we didn't know that what it is. And he was distressed. And mom said, yes, he's in distress, but the main presentation was cough and cold running nose. So we didn't know whether this is coming from abdomen or elsewhere. So because he's 20-month or 2-year-old, and we couldn't really go ahead with the straight away jumping to abdomen. So you can see this is, I will share these slides with you, so I need not to repeat everything. So here's a febrile, vomiting, and abdominal pain. So obviously he's arching of tummy, but it's very non-specific, and had a 1 or 2 episodes of loose stools. So not this sickle cell trait is not massively asymptomatic. It's in the past medical history, had a bit of otitis media, otherwise he's a healthy child. So he attends daycare and no any other illnesses. So we asked whether he has got a contact history of any other problems and couldn't find anything. Panadol is given and no known allergies. So when you're looking at the physical examination, so I don't think you do it in rooms. Do you do the vitals or not?
For
essential?
a 20-month one, no, we wouldn't do the blood pressure.
Blood pressure, yeah.
We wouldn't have a SATS monitor that worked on a
Yeah,
on a
yeah.
2-year-old. We would do the temperature, the respiratory rate, heart rate.
Yeah, it would be extremely hard for even my rooms to do the such monitoring in the small babies, but I struggle.
Yeah.
So definitely it looks like a febrile child with good saturation. Blood pressure is not alarming, within normal range, 90/50. It's not essentially tachycardic or tachypneic. So you can say that he is easily rousable. So you can say that the ENT examination is clear tympanic membranes and oropharynx is clear. Or any other abnormalities, cardiovascular system is normal. So okay, the chest examination. So this is the presentation was written or being done after the diagnosis. So not the presentation, the case, this is a real case. So when I looked at this is the case notes, and someone said retrospectively, is like the notes written some of different things, but at the initial presentation there was no raise, no crepitations, no any other entry reduction of air entry. So chest examination was normal, but later on someone wrote like a query raise, but
yeah,
I would disregard that. So abdomen is voluntary guarding. When you say voluntary guarding, and I don't know whether this is a whole abdomen is holding like this, so it's not peritonitic. So some people doesn't like the idea of voluntary guarding, but it's not a peritonitic. It's a difficult term to describe, and some of the surgeons say there's no such a thing called voluntary guarding, but people are not letting to. It's more like a guarding of the tummy by like this. Like I think almost scaphoid abdomen. And diffuse tender is very difficult. 20-month-old, you palpate everywhere is tenderness. And the bowel sounds first person, no any masses felt. So the rectal examination, in the sense, this is, when you say rectal, this is not a PR examination. This is just looking at outside, and we looked at in the outside and see whether anything in the rectal anal vault or any blood in there. So why we suspected this examination, why we looked at rectal? Because fever, chest infection, abdominal pain, or distress, intersusception is a very common thing on the babies. So it's not uncommon. We see at least, if I do 4 shifts for a week, I might see at least 1 or 2. This is quite number. Intersusception is not that uncommon. So always remind, this is a take-home message. Out of all this, the talk, and after 45 minutes, if you want to take one take-home message, the message would be always, if a male child, look at testes. You know why I'm telling this? We have missed many times torsion of the testes and torsion of the epididymis because we didn't examine the testes. So we even recently, we missed the testicular pain. I'm present with the low abdominal pain. We look at the patient. I look at the patient with things. I look at the testes. Okay, this testicular examination was normal. Then we discharged the patient, went to Nolanga, readmitted, and actually, when I saw the kid was relaxed and we saw testes. I didn't really look at the testes and touch the testes. It's my honest opinion. So I did it very recently. And when he was relaxed, I didn't go and look at palpate. I thought it was, both testes were there. Unfortunately, when you looked at again, abdominal pain, it was a retractile testis. Some reason when I looked at, it was there. It disappears, and again, tummy pain was torsion of the epididymis, but we didn't see. I missed that. So make sure that if you have a tummy, if you male child presented with the abdominal pain, make sure that you look at examine the testes. So when you do the testicle examination, just because of the privacy now, I wear my glove, and I minimum the skin to skin contact, because so many litigations are happening. We get complaints after complaint for certain things. So this is a bit of tip. The testicle examination, make sure that precautions, chaperone is around, and don't take anything granted nowadays. And things might bite us. So the take-home message is abdominal pain, male child, test genital examination. You can say that we universally do the blood. This is a white cell count 20,000, and we did the cultures. Because I set up. We would have not done cultures on this patient. If you say that I would not do the cultures, what happened? Now I set up the order sets: general sepsis, abdominal pain, like a drug overdose, near the DK first presentation, DK second presentation, like in Oasis. I put some different order sets. So one of the order sets collectives is with the culture. You need not do the culture for this child. There's no indication for blood culture. But anyway, EUC was normal. So we did the X-ray, little bit of bowel gas. Doesn't look like obstruction. But we can't see the. When you look at the X-rays, abdominal X-rays, we look at few things. We look at the bowel gas, shifting of the bowel gas, air fluid levels, and make sure that we look at the costophrenic and cardiophrenic angles. So if this is maybe underexposure, not properly exposed in the area. So we want to look at these areas when you do the X-rays. So that is the whole idea. Very interesting. We had the child gone to he's a 15-year-old, came with abdominal pain, gone to general practitioner because of he was fasting for his Ramadan for his last year. He was fasting, gone to general practitioner, thought of this could be gastroesophageal reflux, given some proton pump inhibitors, did not settle well. So he came to us. I thought of it the same, but because he's so much of in pain, got it on an ultrasound scan, checked the blood, everything was normal. But we do the X-ray, direct X-ray abdomen, just X-ray abdomen to make sure this is a gastric perforation. No vomiting, severe pain. But I'm very sure that this sort of presentation is rare, but rare things happen. I'm not here to talk about rare things, but I thought of this just to put that also into your mind. These things could happen. So we couldn't find out what it is. So we did the chest X-ray. So you can say this is a chest X-ray, shows some pneumonia. So it's the lower lobe pneumonia on the left. So that could be one of the reasons with having tummy pain. This X-ray is not like a greatest X-ray to explain this finding, why the abdominal pain usually is coming in the right lower lobe pneumonia, because you share the same amount of nerve over the perineum with the intercostal nerves. It's radiating to the abdomen. T10 mainly is notorious for these things, but this is a referred pain. So mind you, I put this case not to scare anyone, but to say that this is an unusual presentation, but always kids, because GP practice is a very common presentation of abdominal pain. We should not be just to walk down for abdomen. We think laterally why this is happening. Is it a mesenteric adenitis because of the throat infection? Are we missing pneumonias, or are we missing anything in the abdomen? Solely is abdominal pathology. So another reason for this case is looking at the differential diagnosis and include to make sure that abdominal pain is not only coming from abdomen, it could come from the testes, it could come from the chest, it could come from the throat, it could come from the metabolic disorders. I'm going to talk about that in a minute. All right.
Just before we get there, let's just jump to the chat, if that's okay, because we've got a couple of questions there.
Yeah.
Oh. Move the camera down, Gamage, bullying young
Yeah.
children. Yep, no, that's all fine. So let me just see where. Yeah.
Yeah.
Okay.
Sorry, I was pointing the guarding. Sorry, this is a.
Just come
Yeah.
closer.
Sorry, I was. Oops.
Come back down. You're right.
It's coming. Okay. I was guarding on the tummy. It's a voluntary guarding. Anyway.
Yeah.
Yeah. That's what I was following in the tummy. Okay, all good. Now, I would say belly pain, abdominal pain. You can say the number of cases here. What I do is I will not looking at the slides, but I will say that what are the common presentation. What I see in every day in the emergency department or in my rooms, abdominal pain is coming with the surgical emergencies, like coming with interception, acute appendicitis, intestinal obstruction. Most of the time I get referral, or we found out mesenteric adenitis, lobar pneumonias. And sometimes we get patients with foreign bodies, swallowing foreign bodies, iron and button batteries. We get abdominal pain. And those are the surgical or emergencies what we see. Non-surgical, non-emergencies, almost 60% of presentation is constipation. Then we are talking about are the intolerance, inflammatory bowel disorders. Those are in the lower, more in the lower. Perforation, I got only one case for maybe last 5 years. I'm not 100% sure. And sometimes you get abdominal pain, testicular pain is common thing with abdominal pain. And other thing is a porphyrias is a rare disorder, but it's there. And some people giving medications, and those are the common things what we see. And say about less than 1 year on infants, irritable infants, and we get a lot of allergies like food protein induced enterocolitis coming with abdominal pain, or some sort of unknown allergies. So always is bigger kids, it's not always is a tummy, that is coming with more in the functional abdominal pain. We're looking at, so I have a couple of children, is having abdominal pain. We have gone to the town to find out what are the reasons, including CT abdomen. It's quite extensive, but couldn't find any reasons. So we always think about what else could it be. You might get a lot of general practice abdominal pain, mainly functional, mainly coming with a bit of adolescent, teenage group. Females is more common than boys, the males. So that is some of the other presentation is coming with. And you can say that, sorry.
Yeah, no, yeah.
And it's a very vague pain, very vague, not related to no precipitating practice, no triggers, no relieving things, can't describe the pain where it is localizing all the time there. And when you look at the examination, they won't even let you touch your tummy. But when you're looking at monitor, heart rate, pulse, blood pressure, temperature, everything is normal. Every aspect is normal. So you may have to investigate, but because these things are no one want to bite you. So probably what I do is I will ask for ultrasound scan. I will do some blood, including lipase to find out anything pathology. Ultrasound scan, I mainly look for suprarenal glands, any bleeding, ovaries and hematoma, those things, and looking for bleeding into ovaries and that sort of things I ask for. Then ask for the X-rays and see whether X-rays I do for 2 reasons. Because of the one thing is looking at the bowel loop dilatation. Second things I can visualize as sacrum, because the kids can have the spinal paraplegia because of the smooth tethering of the cord, can have or miss spina bifida. So that's the reason we do the X-rays of the children or the young ones, looking at any cord abnormalities, how far fecal loading, or any calculi. Sometimes you can have a nephrocalcinosis in staghorn calculi in the young children. because they might have renal problems, metabolic disorders, but undiagnosed. So we found some sort of a things, not common, not very common. It's just about, we found out 1 cases or 2 cases for last maybe 10 years. And we found out some button batteries, sometimes it's iron tablets we found, and the hair pins and the clips, so many non-edible things we found. So it's worthwhile to just to consider X-ray, especially children with autism spectrum disorder. So one of my colleagues from Port Augusta is treated with abdominal pain. We couldn't find anything, so he was constantly vomiting, and then we found out the massive some sort of a the metallic foreign body in this kid's stomach. It doesn't go from the couldn't pass through the pylorus. So likewise, you will find vague things. So if you get children with developmental delay, so make sure that you maybe a little bit over investigate and think about non-medical causes like a swallowing foreign bodies and that sort of a thing. Am I too fast, or is it?
No, you're okay. There's one question in the chat too. Let's just grab that quickly. Incredible Bisperinga. Yes, it was. So you're saying with school age kids, then you'd be doing an ultrasound of the abdomen, an X-ray of the abdomen.
Yeah. So in the school age children, so put it in this way. Now I always looking for what am I looking for? When I'm investigating, I always write it like small things. What am I looking for? If I'm looking for abdominal pain, ultrasound scan, I'm looking for any problem in the suprarenal glands, whether it's having an adrenal suprarenal gland hemorrhage. The female, I look for asking for ovaries. I always ask them to go full bladder or give a bottle of water, go and get an appointment, because of the ovaries, if the bladder is not full, ovaries can't come up. So they can't visualize, has to have full bladder. So looking for ovaries, because we don't respect torsions of ovaries as we respect to testicular torsion. Testicular torsion in 6 hours in the ovarian torsion would be the same, but some reason we don't pay that, doesn't consider as a torsion of the ovaries is a medical emergency. Okay, going back and looking for children, especially some subcontinent coming with African, South Asian origin, we look for gallbladder, gallstones, because those people have a Mediterranean thalassemia, can have a gallstone. So I'm looking for, so fasting again is a good thing because gallbladder dilated in the fasting. So hepatosplenomegaly, not really, because what are we going to do with hepatosplenomegaly? It's a clinical diagnosis. Any abdominal masses, undiagnosed things we're looking for. Sometimes we're looking for, we might find, as you said, suggested is renal stones and things. Mainly abdominal masses. Sometimes it's the kids, neurogenic, the nephroblastomas, incidental findings, and Wilms-Tumor, so like a nephroblastoma and retinoblastoma, the Wilms-Tumor. So those are the things we're looking for, abdominal ultrasound scan. So then we're looking for X-rays. X-rays, as I said, we look for bowel loop dilatation because of the abdomen, maybe having massive fecal loading, any foreign bodies. What am I looking for? Any sacrum abdominalities. And how far is it? Sometimes you have a bowl of poo collected in the rectum. Whatever laxatives you give, seepage under the bowl of poo and come in here. There's no way you can take this bowl of poo unless we have like giving the bottom and the top. So that's what we do in emergency. When you do the X-ray, we look at the X-ray. Mom said perfectly well. I pull out the Bristol stool chart. I said, tell me what sort of a stool are you going. Then it's a very easy, good tool in the Queensland Bristol stool chart. 1 to 7. 1 is a severely constipated. 4 is normal. I asked, okay, tell me what sort of poo you're passing. Most of the children says 3 or 2, but mom said regular poo, but they're reluctant. They don't accept constipation, but it's there. And as I said, foreign bodies. Then I look for these things, but I universally now do. Because when I said these patients referred to emergency department or referred by GP for my rooms, most of the blood investigation being done. I need not to repeat these things. But if you're looking for again, Hemoglobinopathies, we're looking for any gallbladder, those things, because abdominal pain, gallstones. This is not common causes I'm talking about, but still we do. Lipase, I added my lipase because amylase is no longer valid. We do the lipase. Liver function test, renal function test included, and the full blood count, nothing else. Those are the basic investigation, and the C-reactive protein, look at whether any inflammatory markers. Some of the investigation I can't justify, but these are my basic investigation before I go to the next level. And then the urine, I hardly do stools unless I'm suspecting abdominal pain secondary to ulcerative colitis or Crohn's disease. So I don't ask for the stool, except a couple of occasions, abdominal pain coming with reflux symptoms. I ask for H. pylori, antigen in the stools, and when you do the one blood cells, I do the H. pylori antibodies. So what's the place of breath urea test? It's a good test for looking at H. pylori. It's not uncommon. We have seen a couple of patients in the teenagers and things, but collecting a kit, doing the test, 6 to 8 weeks we're talking about. So I don't do, but still I can do a H. pylori antigen in the stools, maybe non-specific, and then the antibodies in the blood.
Yeah, and I think I mean I often do a Giardia and parasite PCR because I work in the hills, and there's a lot more of those parasites in the hills than what there are in the city. So I think it probably also depends on where you're working.
Yeah. I mean, yeah, it's a no harm because it's a doing that.
Yeah.
And mind you, because if you find something parasites it's not causes, because what's the treatment unless symptomatic?
Yeah.
And the symptomatic disease is again inverted, isn't it? How symptomatic, how you worried. And when you find out this Giardia things, and then people tend to say it's very difficult to reassure. And you can do it because you're in the general practice. I can't do it because one stool report won't come to come in 3 days later. For me, to collecting is again practical issues doing that. But there's no right or wrong answers. As I said, Jared, before, only one person, maybe colleagues, is having symptomatic nausea, vomiting, abdominal pain. We decide to treat. But if you ask for infectious disease consultant, he said don't treat.
Right.
So.
Right. Okay.
Yeah. But it's giving. I have seen my colleagues. I would never ever criticize someone else's management because that is the management done. Treat. If someone treat, just treat. If you decide, if you can justify why you are treating, just treat.
And what about celiac serology? We often get.
Yeah. So we often do celiac serology, and the celiac serology, mind you, again doesn't come as an isolated abdominal pain. What we are talking about here, 2 types of abdominal pain. One is a abdominal pain with a short duration, 1 or 2 weeks, versus abdominal pain which is a months and months. So if you have a chronic abdominal pain, I would include celiac and porphyria in the young girls who is having a young adolescent before they get menstruation and sort of a thing, people age. But celiac disease, celiac strain is again. It's a chronic abdominal pain. You try certain things, it's not going to help. You ask for celiac strain. By the time when you ask, they are already in gluten-free diet.
Yeah, we see that too.
Yeah. So
we just have one question in the chat. I'll just go to that quickly and then we'll move on. Symptoms with pathogen on lab test usually ends up with me recommending treatment. So that's yeah. That's So that is there are the legal obligation to say that you have to treat this. But when you're looking for recommendation whether we should treat this, no, there's no recommendation for treat it. Even for blood and mucus diarrhea with abdominal pain, unless they are toxic, we don't treat with antibiotics. Right.
That is the recommendations. But having said that, you are independent practitioners, you have your own thinking, and you do it depends on the available information at that time. So if you think that you should treat, it's a chronic abdominal pain, you would have done everything, this is the only thing is remaining, treat. And it's not going to end of the world. So it's an individual practice. But when you're looking at the evidence base, if you look at the evidence base, everyone like to do evidence based medicine, but what do? We have to suck in the one side disease, the ID infection, because it's infectious disease, and other one is your judgment. So I would say that use a judgment and see whether you have done all these things. This is not being treated, but this kidney has symptoms to treat.
Yeah.
If I'm treating this sort of pathogens, I always ask them to do the probiotics and things, and make sure that you have a normal gut flora.
Yeah.
Because these are the parasites. Who knows what they are killing? Yeah. Always is a proper history would be the things. Mind you, this is abdominal pain is a very stressful condition, because mainly with the teenagers and the young adults with hypochondriasis and things. Okay, so this is some. I'm going to skip this one for UTIs. Is one of the commonest cause of abdominal pain. In the UTI is not. UTI doesn't come every time it's the fever. Couldn't believe that, because it's we do routine UTIs. I mean, urinary screen at the emergency department. Every child. I don't think general practice you can do that. So it's not big no for. And we found out the UTI present with the sole abdominal pain without having associated symptoms, the fever and vomiting, nausea. But this is in the either extreme ages, very young age, less than 1 year, or it could coming in the older girls. So it could be cystitis, but the very young age doesn't present with the abdominal pain, but they present with irritable. So any irritable babies, I do the urine exam. So. So we talk about this, I'm saying, okay, we talk about this, I talk about mesenteric adenitis. And this is one, it's a DKA. We have a very good GP colleagues. So 99% patient referred by GP. For DKA is new diagnosis. They present because DKA again, abdominal pain is not a long presentation. Their presentation is a very short presentation with abdominal pain. So why do they get abdominal pain and vomiting? Because of the DKA is the acute gastric dilatation. Don't ask why do they get acute gastric dilatation. I don't know. I mean, yes, they get acute gastric dilatation. Maybe someone you can tell me, but that is a cause for abdominal pain in DKA. So there's a short history: polyuria, polydipsia, losing weight, gone to GPs, and abdominal pain, and gone to general practice. They said do the sugar or urine, simple test. We receive a phone call and say, look here, this is the reason. So we get them down. So this is one of the things which is not uncommon. Again, these patients could present as a tachypnea and tachycardia also. So no need to know the management. And I talk about this testicular torsion can present with abdominal pain as a sole the complaint. When you say testicular torsion, it's not only testicular torsion, it's a testicular torsion of the epididymis. So if you look at the it's a very easy to look at, and testicular torsion epididymis. What you can do is, if you get the male child with even % with testicular pain, please look at the testis and stabilize the testis, and get the foreskin and try to not the foreskin, testis, and pull the skin down and look at. You can see the blue dot. You can even for dark skin, you can see the blue dot.
Right.
So, but never ever take a chances and reassured and send to the hospital, because the protocol. This is testicular pain, come to the hospital, and they looked at by surgeon. So because we don't reassure even for when I'm working in the country, I said that a blue dot is there, but I don't take the surgeon's responsibility. I said, this is the thing, are you sure take these things? Because you can say all the cremastic reflex, normal axis, not horizontal axis, but still the guideline says to talk to surgeon, so I would still talk to the surgeon. So mainly it's not testicular torsion, it could be a torsion of the testicular appendages. Now, this is the typical presentation of the written is a typical presentation, but what you and me get it, this is not a typical book presentation. Incarcerated inguinal hernia, so this coming with abdominal pain, but they come with more in the premature babies or extreme premature babies, more in the young population babies, they can have incarcerated inguinal hernias. Again, your embryology, I can't remember how does it happen, but anyway, indirect inguinal hernia is common in more in the newborn premature. Not much of time to testicular descent. So this presentation, I have seen 1 or 2 with incarcerated inguinal hernias coming with abdominal pain. It's very tender, more in the inguinal canal than other ways. When you get the more history, moms tell us, yes, we're having a note of the lump. Only one patient I have seen, this is a torsion of ovary, or we call ovotestis, in a young girl, again, less than 1 year. So when I was working in Port Augusta, so that is only one for 15 years. I have seen only one patient. It's an ovulation of the ovotestis. We call ovotestis, but some reason it's gone down. It's a female girl, so female. So that's what we call ovotestis. But how do we reflection on that? Should we change our clinical practice? Yes, we're looking for abdomen. We don't only look for abdomen. That means emphasizing. Looking for inguinal canal, looking for genital examination, even for the female child, and looking for any palpable areas in the labias and go down. So this is not included. So I was working in the emergency department yesterday. I was doing the evening shift, the ED evening shift. I saw the 12-year-old child coming with abdominal pain. So when I look at the abdomen soft, and he's tachycardic, he's a bit of tachypneic. I look at the testes and look at the genital examination. It's like a severe balanitis. I haven't seen that at all. It's like a cauliflower penis. So it says, because if I look at the abdomen, soft abdomen, he's coming with tummy pain. People won't tell us. People expect to find things for us. So that is how I'm re-emphasizing. So it's like a cauliflower. They didn't tell us. Mom didn't tell me. And kids he was 11-year-old, it's a tummy pain. So I luckily looked at low down. I said, okay, urine passing. Yeah, a little bit of having a pain when you're passing urine. Oops, how many days going on? 5 days. And then I said, haven't you seen a GP? Yeah, we went to GP. GP is the one who referred to us. Got a letter. It's written as everything written is. So he looked at. GP looked at. GP said this. The doctor, whoever looked at, he said they infected balanitis, and he written. But mom didn't tell me anything. Just think, what is my situation? I'll be in front page in Advertiser today if I don't look at the page. They don't tell us. They expected us to find, and even for GP's letter is folded into multiple, about, the A4 paper is folded into multiple folds and having a tiny bit of this. Where's the letter? Yeah, took the letter out. Okay. Yeah. Not being given to triage. So make sure that, again, emphasizing what's important of the genital examination. Yeah. If you don't look at, you won't know. So you're looking at sometimes we have seen a couple of couple of girls with foreign bodies, even the young girls, and having the foreign bodies in vagina. And other thing is hematoculpus, and the kids are not, they say you got a 12-year-old child with abdominal pain and not menstruating, maybe think about whether it's the same perforated hymen and having a hematoculpus or something, you know. I have seen only one patient, so it's not that common, but keep that in mind. So again, when you look at the genitals and you can see the labia adhesions, what's the common practice for labia adhesions? What do you do? You apply or anything, or you don't do anything, or?
I'm not sure.
I will tell you, before you guys born, I was in med school, majority of, okay. So what we did those days, we do the exam, labial adhesions, we separated. And we put some either moisturizing cream or maybe having steroids. So what we found out is the more we separated, more is coming as a couple of years later, is more and more UTIs and having scarring and so many things. Now we don't do that at all. That is, I'm talking about 20 years ago is the practice. Right. Or 20 or 30 years ago is the practice.
Yeah, I've never heard of it.
So we did those days.
Yeah.
And now we don't do anything, even for UTIs, unless they become recurrent urinary tract infections.
Yeah.
So what you can do in the general practice, if you have a labial adhesion, you can apply some, I'm very sure that you guys are doing this, the steroid application. So you can steroid, or you can do it. What is this? Estrogen, what do you do for adults? It's yeah, I can't remember. So it's an estrogen, the cream. So
yeah,
something like that. Something. Yeah. I think they use for perimenopause women. So that's what we do. Yeah. Same as the kids with tight phimosis, and we do the steroids. Yeah, something similar.
Someone in the chat let me just grab that quickly too. Yeah. Female baby with hernia containing ovary.
Yeah. That's what I saw in Port Augusta. Yeah. So we talk about hematoculpus. Yeah. Okay. Now, this is what I talk about this neuroblastomas, Wilms tumors, and those are common. And so how do we find out? So, it's difficult to examine abdomen. Realistically, how do you examine abdomen? Kids, very difficult. But at the time when we put, they stiff the abdomen. What my method is, I percuss. I put the lung, starting from lung, go down here. I talk to myself, lung, spleen, soft. So I continue the same note, lung, go here, liver. So then I talking to myself, I reminding I'm looking for any masses. If I say dull, the area where I should not be dull, yes, this is something is peculiar. So we look for things. That is what we are here for. We're looking for abnormal masses. We want people to give a name. At least if something not sure, we send it to ultrasound scan. 99% ultrasound scan as a normal. But you find one Wilms tumor, that is a money is there. Because sometimes you might feel something, maybe dilated bowel lobes, or maybe massive feces, who knows. But have a low suspicion, young children less than a year. Abdominal examination is challenging. This is a trick I do, percussion. So weight loss, yeah. When I put this slide because lead intoxication. When I was working in Port Pirie is it's a
country town. Yeah.
Country town, and it has a lead smelter. Yeah. And the Port Pirie, and usually it's a lead level is high in most of the kids in Port Pirie, and the Port Pirie area, they do the universal screening. Every child with do the blood test universally by our GP colleagues, so find out how much of lead they have. Now, because so much of those things I'm talking about when I was a registrar in 2007, 2008, 2007, there's a massive the number of patients we found out lead toxicity in Port Pirie. Now it is a very much less because houses are new. It's not from paint, it's coming from the paint. There's no lead in paint now and no old houses. And the lead smelter itself has a lot of precautions. So how do they dispose the waste products?
Mm-hmm. So that seems to be a where you live situational.
Yeah. So that is same as country. There's Sterling and that area. The country you look for parasites, and this area look for where are they coming from, because your practice. And you might get different places, and people say it's coming from, where are you? I live in here. So where were you? Okay, where was he born? I born in Port Augusta, Port Pirie, that area. So we think about easy the things. So when you do the lead levels, and make sure that you do the iron levels also, because lead is replaced by iron and you get low iron. So with the high lead levels, you replace with. I have never done penicillamine. So as a treatment for lead intoxication, what I have done is given more iron, some iron. So then it's replaced slowly. When I was back home in Sri Lanka, I have seen lead levels in the X-rays, because in Sri Lanka, what we do is, the fishing sinkers. Mm-hmm. So we made the sinkers. So how do? We go to the printing presses where the printing presses have a lead as a printing, and once they print few batch, they discuss and they put it in the bins. So we as young boys, we collect those things and we melt those things and making sinkers. So sometimes, and we found out the people with encephalopathic lead intoxication, but we don't see here. Yeah. We have seen few lead encephalopathy patients in long 10-20 years ago in Port Pirie area, but not anymore. No. But this is something to remind. So this one is the same one. This is a lead level, and treatment is a chelation. Now this is one of the good topics.
1 sec. There's another chat. Let's just grab that one first. I had the patient in my clinic. Female bear with hernia.
Okay, join the club. Now this is one of again not uncommon abdominal migraine. Okay, this is one of the common. I would say, like, I see most of the patients abdominal migraine now than I have seen before. This is a cyclical vomiting, recurrent severe abdominal pain, sometimes nausea with or without. Now the challenge is, so you can say this is abdominal migraine, cyclical vomiting. Abdominal pain now is coming without vomiting, so solely abdominal pain. But when you're looking at the guidelines, so abdominal migraine should be more than 6 months as intermittent abdominal pain, lasting something 1 to 7 hours, and with some triggers. So when you're looking at the abdominal migraine, but this is very easy to treat. It's not that you can, in your practice, you can use some periactin. And periactin is maybe comes as a 2 milligram, 4 milligram tablet. You can use with the 4 milligram once a day, 4 milligram 2 times a day. It depends on. It's a very easy to treat if you think about abdominal migraine, but it's not going to harm. Also, you can say, okay, why don't we use 2 weeks of therapy and see how things are going? But at meantime, so those abdominal migraine is common again, girls, female. Abdominal migraine is common when the family history of migraine is there. So you can say some of the triggers if it's a true abdominal migraine, not factitious abdominal migraine or functional. God knows which one is which, but you can clearly say more than 6 months associated with cyclical vomiting and have a family history of migraine, maybe mother or maternal gland or things, and having a lasting 1 to 7 hours and precipitating relieving factors. So you treat it.
It sounds like a diagnosis of exclusion to me.
Exactly. Yeah. But we found out few patients.
Yeah.
Now, so 8 attacks per year. Each attack is 20 hours. So now, so this is, but I use periactin now. So I have less than tendency to use triptans and NSAIDs. So but when you say triptans, we are talking about the nasal sprays or immigrant nasal sprays. So, but I don't use it now. Even for migraine, so we don't tend to use a triptan. And what we use is a immigrant nasal sprays.
Yeah.
Is it what you use now?
Yeah, we use
Nasal
sprays,
yeah.
wafers, lots of
Yeah,
things.
so we use the sprays now, according to current
Yeah.
recommendations. So abdominal epilepsy is this is not common presentation. I haven't come across with paroxysmal episode of abdominal pain and coming with so I just put this is included from the from just when I look the literature I put it. I haven't come across with any of the patients with abdominal epilepsy.
Yeah.
So my knowledge about abdominal epilepsy is very less.
Yeah.
But again, if you think that this is coming with abdominal pain, you know, same as absence seizures, they're coming short-lasting abdominal pain, staring episode along with that, consider that, but I never seen these cases. My knowledge is very limited.
Yeah.
So sickle cell crisis again is coming with different ethnic groups, and it's not an uncommon thing. So sickle cell crisis, so always is it's very easy to find out. I have seen my GP colleagues is sending the patients with abdominal pain and say that this is sickle cell. Yes, you may have to send to the emergency department because of the hydration, pain relief, treat for infection because their spleen is a hyposplenicism. So those are the straightforward things. So of course it's not these are the straightforward things. Porphyria. So this is what I want to tell you is again this is not common presentation. So they come with abdominal pain, but they usually most of the time they have the photodermatitis. So what happened is they have a photodermatitis, but we don't investigate for porphyrias. What we do is we ask for antinuclear antibodies, rheumatoid factor, all these things, going for SLE path. That is what we are missing this diagnosis. And that is not common. I don't know why, because we don't ask for a porphyrogen in urine. It's a very simple test. But I've seen that when you get a skin rashes, unless it's having every time when you go to face and you think about porphyrias, I don't think normally that was not in my differential diagnosis. That is again, if I exhausted with all these things, celiac, abdominal migraine, and functional abdominal pain, all these things, then I will think about this is the last resort sort of a thing.
And normally after puberty.
Yeah.
Okay.
Yeah. So rarely present before puberty. So.
Yeah.
So you for pyrinogen is a urine test. Now before we go, so
Hold on, there's just one in the chat. Let's just grab that quick. Do you use the periactin for prevention or to treat the acute
yeah,
attacks?
I would the pediatric more for prevention of treatment. So acute thing is the simple pain relief for anything. So unless you pathway is like this, you go pathway one arm is you treat for acute things. Okay, you treat for acute abdominal pain with whatever the available analgesia. It could be starting from paracetamol and NSAIDs, and the emergency department, fentanyl, and those things will go for it. And they go for periactin as a more in the preventative aspects. So then still in tummy pain, when you give periactin, you can use the lesser number of analgesia, more in the paracetamol simple analgesics. So I haven't done for triptan for abdominal migraine for a long time.
Yeah, okay.
And the other thing is the HSP. HSP, of course, is a straightforward. Everyone knows HSP as a vasculitis, can have abdominal pain, and usually they have abdominal pain because of the vasculitis and possible ischemia or the urticaria, so not urticaria, what do you call the purpura in the gut wall.
Yeah.
Yeah. And I can't think about anything else. This coming with abdominal pain. I'm happy to answer any questions or anything.
Yeah. So the only question I had was really about
yeah.
those intolerances.
Yeah. Sorry. The lactose intolerance, the fructose intolerance can come as abdominal pain. Yes, it could come as abdominal pain. So why we are not investigating? So the reason is lactose intolerance is looking at the lactose. Lactose is a large molecular substance. So if there's a lactose intolerance means, so it's used as osmotic diuresis. The large colon where the water reabsorb is osmotically active particles is retaining is there, and is the water comes and forces the water is stored. So before they come abdominal pain, they have diarrhea, perianal excoriations, and perianal excoriation and profuse smelly stools. So that is a presentation of lactose. Fructose intolerance was the same.
So fructose you get similar to where you get the water.
Yeah. So, but abdominal pain, these things, then we're looking at, yes, this could be the causes of abdominal pain. It's possible because you produce a lot of gas in the stomach because you keep in the lactose and where the other bacteria are producing different enzymes. Yes, that is a secondary cause. It's not that's a primary cause for lactose. Who knows?
Yeah.
But primary presentation is not abdominal pain.
Yeah.
So if someone asks for, okay, can we do the test? Okay, what I do is I'll ask all these things: is this possible? Is this possible? Then you can ask, or can you check the symptom diary? Or can you think back and see what are the food triggers by? Was it triggered by any specific things?
Yeah.
So sometimes it's nowadays, even severe, say about cow's milk allergy, that is one of the things could come as abdominal pain, the milk allergy, because two reasons. One is the cow's milk protein causes gut irritation, same as the gluten. Second thing is a high phosphate load in the cow's milk causes constipation. So milk allergy can cause abdominal pain, can cause constipation. It comes as a circle. So I have seen when I work in the country in the Port Augusta and that area where the indigenous population is high, what they do is that they are either they go to fresh milk very early. So some of the different practices. So then these people are low iron, coming with severe constipation or some sort of abdominal pain. So they come with a moles presentation with a severe constipation. But when you looked at excessive load of cow's milk was given.
Yeah.
So other thing is a kid come as abdominal pain. It's some sort of food protein induced enterocolitis.
Yeah.
There's a different food protein in the gut. Causes same as gluten sensitive things could cause a tummy pain.
Yeah.
Gut localized ischemia. So it's worthwhile to think about what are the history. So what sort of food what are the triggers? What are the relieving things? Anything related with the feed. Sometimes you might say once you have feed and have a tummy pain, think about what it is. Yeah. So did I answer? Or? Yeah.
All right, guys, I'll open it up to the panel for any questions. Chuck it in the chat or, unmute and you can just ask.
Yeah, just ask. It's not massive people. Just ask. Yeah.
Whatever you'd like to do.
And the yesterday patient, so I gave some the severe balanitis with severe balanitis, coliform foreskin. I gave flucloxacillin and then the surgeon called surgeon and surgeon said that it is not enough and gave a tazocine and tazocine.
Wow.
Yeah.
Okay.
But then you can see that how severe it would have been if it was,
Yeah,
that sort of a thing. So it's a quite interesting. I'm very sure that whoever the lucky GP, I can't remember which practices. So some of the good things. So and one of the things I asked some of the question there, some of the chat group here.
Yeah, let's just grab that. Best way to manage kids with rectal fecal impaction to cause them the least amount of trauma.
Yeah, that's
good question, Helen.
Yeah, very good question. Now, so you can manage two ways. So my personal experience, and this is how I manage in emergency. When I was doing the neonatal round, kid has an open bowel for 3 days or 2 days. I said, give a glycerin suppositor. One of the nurses given quarter of glycerin suppositor.
A quarter.
Quarter.
Yeah.
Not full one.
Not a full one.
So bowel in open. So ultimately given full one. So I said, if you treat, I always say give an industrial dose. So industrial dose is a full dose. Because by looking at you opening up the sphincter from down. It's not going to any harm. You're just going to anyway through the sphincter, whether it's a quarter, whether it's a half or the full glycerin suppositor. Yeah. You all or none. So if you come with the emergency, or what I do is if so we see 70% general practice in emergency. We see 30% or less than 30% emergencies. Yeah. We see like you guys. So what we do is Bisilax and Microlax. I do the combination together.
Enema,
yeah. And then top up with Microlax, sorry, the Osmolax. Young children, Coloxil, not the 0.3 ml 3 times a day. I give a bit of higher doses, 0.5 or maximum doses. So I ask them to titrate, give a Bristol rule chart, printed copy, and this is expectation, increase up to this, make sure that hydration is okay. If I think that fecal loading, I'll give a full suppository, 1 or 2, make sure that get good results. I have done only once to the manual evacuation, only one, that is developmental delay child, not a normal kids I haven't done. Surgeons would have been done that, I have never done. You guys would have been done this. So the take home message is if you are giving laxatives, give a good dose laxatives. So start with a higher dose and titrate lower dose. But unfortunately, when you're looking at the women's and children from Movicol guidelines, it says go slowly build up 1 sachet or 2 sachets or 3 sachets. So either way you can go, but because of the abdominal pain and risk of aspiration, I start with higher dose. This is achieved. You can either step up to go there or slowly come back. So, but if it's suppositories, but I don't encourage, usually have a regular suppositories. This is something I hate. Someone to put a regular suppositories, because just thinking, I always treat with respect. And I always think, this is my kid. What do we do? So I ask this question all the time. And I'm sorry, I'm a bit of sidetracking. My registrar, we found that the 10-month-old with urine, candida in urine. And other consultant is one of the junior consultants was working with me. And that was around midnight, and found more than 1,000 candida species in the urine, and kid also been intensive care, and before that, this time coming with fever. I'll give 1 dose of IV antibiotics and admit. I said, this is your son or your daughter, your kid. What do you do? Do you ignore this until tomorrow and to do the general medicine people to settle, or what do you do in your kid? Okay, I call ID. So likewise. So we call the infectious disease. We got advice. Doesn't matter. We have to ask for things because we treat with respect. So what happened was I don't like the people to have a regular suppositories after suppositories after suppositories, because we are putting something behind the anus, and we have respect to the external anal sphincter. So if you are treating, you were treated one-off things as a good dose, get the good results.
Okay, and in the chat we've got, thanks for the meeting, have another one. Great. Okay, see you, bud. How long do you give maintenance therapy for constipation after this?
That is a very good thing. You can give months and months. I will tell you why. The reason is because you try to, if you and me constipated, what do? We might get something, or we drink water, we exercise, we do it. And we eat, okay. Our body, we talk to our body, okay, we might eat a bit of fiber, salads, or we might sometimes can have milk, and we do it, or probiotics, and or we take laxatives. Kids can't do that. But our bowel is our sphincter, our gut is already formed. The kids, what happened, we know how to go to toilets. The first thing is kids has constipated abdominal pain, hard feces going through the anus is a very painful thing. They stop going to toilet. What they do is cross legs, come to the edge of the table, stand on the edge of the table, squinting, and they have then the incontinence. Toilet training is a nightmare.
Yeah.
And you just have the tube, the one end is blocked, we're trying to push. You straight into lazy bowels, bowel loop dilatation. Same incident as a Hirschsprung's. So that is the reason I said this is going to happen, not going to happen, I mean in a good way. So we don't want kids to not to have toilet train. We don't want to toilet is unpleasant. This is a painful exercise. I would say use for even for a year. Doesn't matter because these things are not going to absorb into your body.
Yeah.
It's going to nicely pass it. So give a bristles to a child. You can not every day, you can say every second day, every third day.
Yeah. Just aim for that soft sausage.
Yeah.
Yeah.
So then kids, they will learn.
Yeah.
You know.
All right. Well, if there's any more questions, just chuck it in the chat. We'll take one more. If not, we'll call it a night. So thanks so much, Lalith, for your time and giving us a presentation on abdominal pain in kids. I really appreciate it. It covered actually a really wide range of topics there.
Thank you very much.
which was great.
Take the presentation and share it.
Yeah. Well, it's recorded, so all our doctors can watch it at a later date whenever they want to. But
No worries. Thank you very much. Yeah.
We really appreciate your time. It's not.
Thank you very much. Have a great evening.